There were so much cultural barriers. So what next? The turnout was low. So for us to achieve comprehensive public health education, we must move. What can we do? We must leverage on our digital health technologies. Your phone can be your power. We must look for a way to integrate HPV vaccination into our school curriculum. SOGON, that's what we have, SOGON, NMA, and other associations in Nigeria should please come up and be able to meet our federal government so that will be integrated. By then, the young girls will be the one that will carry the message to their mothers. Then we need to train health workers. Most of them in communities, when it was rolled out, they don't even understand what HPV vaccination was all about. We want to get there. We need to get our health workers. Have to move faster. Then, we are Nigerians. If you want to achieve anything in Nigeria, you must get the religious group, the pastors, the imams. We want our HPV vaccination to move in. We must go to churches and mosques. They must come on board. Then finally, there is need to use media campaign. There is a lot you can do. There are things we can do using the people that have survived cancer. There can be another group that will join us and move up with us. Sorry, we started late. So that was what led DAFLIC to bring what we call HPV Aware in Nigeria. What is it all about? They want to educate the medical practitioners. So those medical practitioners should move in, educate their patients will educate the communities, and a lot like that. That will lead to increased uptake of HPV vaccination. That's why they are here with us. And they've also developed 8 series lectures. We are having the first lecture today, and I will soon talk about who will take over the first lecture. So intermittently, we send you webinar link. Please endeavor to click because it's going to run. We have 8 topics to discuss by experts, and at the end, we are going to have much improvement in our HPV vaccination. So today, our Secretary General, we all know, an erudite professor, an achiever, a CMD, will be the one to take our first series. And the title is Progress and Challenges of HPV Vaccination. Just as a summary, because there are people that if you want to read their CV, it will be too long. But we've tried to summarize him briefly, that he is an associate editor in the Journal of Basic and Clinical Reproductive Sciences. She's a okay. As a summary, he's a fellow of West African College of Surgeons, National Postgraduate Medical College of Nigeria, and International College of Surgeons. He's a researcher. He's a writer. He's an administrator. He's also he has occupied a lot of positions. He's also currently occupied, and he's our SecGen, Society of Obstetrics and Gynecology of Nigeria. Please join me to welcome Professor Kanayo Azubike. You're welcome, sir.
Thank you, Maureen. You've given the lecture already. You've given the lecture already. Olainka, where is my lecture? Give my lecture, my own. Thank you, Dr. Maureen, for your kind words and introduction. She has said almost everything. My own is just to run through the first series like she had said. But it's just to make some corrections. The lecture series will be after this one, we're going to have 7 more, pioneered by Doflik, supported by Sogon, and the speakers will be Sogon members, and is alluding to the sub-theme, which are strategies for prevention of gynecological cancer, as one of the sub-themes of this conference. So we will just go through the topic, progress and challenges of HPV vaccine. The next lecture series will be virtual, and it will be taken by the Honorary Treasurer of Sogon, Dr. Fatima Zara Mairami, on the 7th of December, 5 to 6 p.m. The links will be shared very soon. So you can see what the dangerous virus, human papillomavirus, is doing to our system. This is just a way of saying papillomaviruses are of several varieties, and they are host specific. And you can see the various vertebrates that they can be in. And there are more than 200 HPV virus varieties. And HPV is primarily spread through sexual activity, but can also be transmitted via skin-to-skin contact. Next slide. We're just trying to understand what this virus is all about. Not all HPV infections end up in cancer. All of us know that as gynecologists. You have the high-risk virus, which cause cancers such as the cervical, vulva, vaginal, and anal cancers. And of course, we have the low risk, the non-causing cancer, generally causes warts. And then you see the natural progression of HPV infection. Between the 0 to 1 year, you have the initial HPV infection, and within 0 to 5 years, either you clear it from your system or it progresses to the cervical intraepithelial neoplasm pathway, which can, up to 20 years, eventually develop as full-blown cancer. HPV-related cancers occur in both men and women, and therefore vaccination of both men and women is very important, and that's what the Cancer Elimination Series is talking about. Not only vaccinating the women, you also vaccinate the young men. And you can see the different places, both in the male and the female, where the organisms are, and then the percentage distribution. What is the burden of this cervical cancer? We need to be aware. Like everything that is bad, you will see the global burden, you will see the map, and you will see that most of the burden is within the African area, the Latin America. You can also see the Asia part of it. Everything bad is always towards Africa, so we have to work hard to get to being in the American series or the other side. Then also the global burden of cervical cancer. Cervical cancer is the 8th leading cancer in the world and the 9th leading cause of cancer death worldwide. And you can see again the distribution globally. Let's bring it down to Nigeria. What is the burden of cervical cancer in Nigeria? Cervical cancer, we all know, is the second most common cause of cancer death after, of course, the almighty breast cancer in Nigeria. And we have evidences from both the Ibadan Cancer Registry and the Abuja Cancer Registry. You can see our evidence there. 36 per 100,000 from the Ibadan Cancer Registry, and then of 30.3 per 100,000 in the Abuja Cancer Registry. And over 99% of cervical cancer cases have been linked to HPV infection. That's why most people will tell you that cervical cancer, in fact, is a sexually transmitted infection. So all emphasis be towards preventing people from getting that infection that will lead to cancer eventually. And vaccination is proposed by World Health Organization as part of global strategy to eliminate cervical cancer. Now let's look at HPV vaccine itself. HPV vaccine produces antibodies that prevent HPV infection. That's what most of these vaccines do. And we have over 200 HPV viruses. Over 40 are spread via sexual contact. 2 cause genital warts, and about 12 of them eventually cause cancer. So HPV vaccines protect against infection with HPV. HPV vaccines act on the following virus variants: the HPV types 6 and 11, which cause 90% of genital warts; HPV types 16 and 18, which are 2 high-risk HPVs that cause about 70% of cervical cancers and even higher percentage of some of the other HPV-caused cancers. HPV types 31, 33, 45, 52, and 58 are all high-risk HPVs that account for additional 10 to 20% of cervical cancer. That is what we are dealing with. And HPV vaccine as a significant contributor to cancer elimination. World Health Organization considers HPV vaccine as an important strategy to eliminate cervical cancer. And you can see there is a vision of world where cervical cancer is eliminated as a public health problem. The following 90, 70, 90 targets must be met by 2030 for countries to be on the path towards cervical cancer elimination. That's why you saw Nigeria trying to roll out the HPV vaccination. Then a threshold of 4 per 100,000 women years elimination is a public health problem. And of course, 70% of women are screened with high performance tests by 35 years of age and again by 45 years of age. 90% of women identified with cervical disease receive treatment, and 90% of women with precancer treated, and 90% of women with invasive cancer managed. That is the 90, 70, 90 strategy. What about the efficacy of this vaccine we're talking about? HPV vaccines are effective in HPV prevention. And you can see the different statements to support this. 99% efficacy in preventing HPV infection in women without prior exposure to HPV. You have significant reduction in anogenital cancer, genital warts, and potentially oropharyngeal cancer in vaccinated women. We also have 71% decline in HPV infection rates, ages between 14 to 90 in the US from 2006 to 2014 with the quadrivalent HPV vaccine introduction. You also have countries with HPV vaccine coverage show a marked decrease in genital warts. The nonavalent HPV vaccine protects against more than 99% of disease related to the genotypes 6, 11, 16, 18, and up to 96.7% for genotypes 31, 33, 45, 52, and 58. And of course, vaccine is preventive, but not therapeutic. And that is the emphasis. No current support for treating exists. You know, because of the various misinformation about the safety of these vaccines, we cannot talk about vaccines without talking about the safety of the vaccines. HPV vaccines are generally safe. And you can see evidence also to support this statement. The nonavalent and the quadrivalent vaccines have similar safety profiles, with the nonavalent vaccines showing a slightly higher rate of injection site swelling and redness, which is almost with every kind of injection that you might have. Reports from 2014 to 2017 show no unexpected safety concerns related to the nonavalent HPV vaccine. The common side effects include mild local discomfort and syncope fainting, particularly in adolescents. Over 270 million doses of HPV vaccine have been distributed since 2006, with no data suggesting serious adverse effects. No safety concerns were found in individuals vaccinated with nonavalent HPV vaccine after previously receiving the quadrivalent HPV vaccine. Sometimes you can have severe allergic reactions to vaccines, which are rare, but patients with life-threatening allergy to any other component of the vaccine or to a previous dose should definitely not be vaccinated, like a warning. HPV vaccine, the past. Let's look at the past of this vaccine. Look at the natural history of development of the vaccine. In 1983 to 1984, HPV 16 and 18 vaccine HPV 16 and 18 was cloned from cervical cancer as part of the natural history of how this vaccine was developed. And then in 2005, the International Agency for Research on Cancer expanded list of HPV types to cause cervical cancer. And in 1995, the International Agency IAC classified HPV 16 and 18 as carcinogenic. Then in 2006, Gardasil, the first HPV vaccine protective against 4 types, was approved for girls and women aged between 9 to 26. And in 2014, Gardasil 9, protective against 9 HPV types, was approved to replace the original Gardasil. And in 2020, the World Health Organization launched a worldwide strategy to eliminate cervical cancer, of which HPV vaccine is a core part of it. And the target is that by 2030, the target date to meet the World Health Organization screening and treatment guidelines that we had alluded before. Development of the vaccines. So you look at a comparison between the quadrivalent vaccine and the non-valent vaccine. The company that makes both of them is the Merck. The year that it was marketed internationally for the quadrivalent was 2007, and for the non-valent is 2015. You see the viruses that they are particularly protective against. You can also see the cross protection for the quadrivalent, while that of non-valent is still unknown. You can see the substrates and the adjuvants that were used in the production, and of course the vaccination schedule, which is very important. You give after 2 months and you give after 6 months for both the quadrivalent and the non-valent vaccines. The present HPV vaccination coverage. HPV vaccines coverage remains low and has a long way to go. That is why we are partnering and endorsing DOFLIC to start this sensitization so that we can drive the coverage better in Nigeria and other places. The global final dose HPV coverage is estimated at about 15%. And you can see the countries with HPV vaccine in the national immunization program already. You can see that in Africa is about 31%, those who have introduced the vaccine in their national immunization program. And you can see the different areas: America, 85%, Asia again like us, 40%, Europe, 77%, Oceania, 56%. And you can see that's distributed in our chart. HPV vaccines coverage remains low and it has a long way to go. And you can also see again HPV vaccine introductions by World Bank classifications from 2006 to June 2020. Introduction of vaccine in low and middle income countries did not take off until 2017, as you can see in our diagram. And 11 of those programs were initiated just as far late as 2019 or 2020. Yet we're heading towards 2030. What is the HPV vaccination in Nigeria, the current status? The awareness of the disease and the vaccinations, as well as the vaccination uptake in Nigeria, is poor. There is poor awareness about cervical cancer and screening. The willingness is high, essentially among parents. A study showed that mothers were willing to accept HPV vaccine for their adolescent daughters. But there is low awareness. About 58% had never heard of the vaccine. Improvement in uptake from 0.9% to 33.2% was reported among girls aged 9 to 13 years. This is a research done by Akiola Ndikom Oluwaseru et al. Availability, cost, and socio-cultural aspects impact vaccine uptake. And you can see the diagram depicting the barriers. You see the cost, you see the vaccine doses and intervals, you can see the vaccine delivery, the lack of knowledge about HPV and vaccine, and of course, distorted fears and perception about the vaccine that will lead to vaccine hesitancy among the people that will take it. So despite the strong parental willingness in Nigeria to vaccinate their daughters, factors such as those I've listed, cost, availability, socio-cultural and religious influences significantly impact on the actual uptake of the vaccine. What are the barriers specific to men? A belief that men cannot contract HPV virus. And of course, the social stigma of sexual transmission of the virus. There's a study by Oliveira et al. What are we to do to improving the vaccine uptake through right strategies? There is a need for adapting various strategies to improve vaccine uptake in the future, because we're heading towards 2030 and we have to work round the clock to see that we'll break these barriers and get our uptake to be high so that our women will be protected against cervical cancer. We have to highlight the positive impact of the vaccination. We have to engage professional networks like Sogon is doing. We have to create an elaborate action plan. We have to develop a crisis prevention and mitigation plan. We have to implement a unified communication on strategy. The communication has to be apt in order to break these barriers and misinformation and reduce vaccine hesitancy. We have to foster political support, and I think the Nigerian government is heading towards that. And the coordinating minister looks like he's determined to address some of this political will to do things. We have to address alleged side effects seriously by giving the correct information like we're doing now. And we have to build confidence among healthcare professionals and among public health staff so that they can also disseminate the correct information and let people not be scared of nothing that has not been proven by science. We have to define optimal vaccination age and, of course, train healthcare professionals. School-based interventions have been also proven to promote HPV vaccination. Education can play a significant role in improving vaccine uptake. So HPV vaccinations should be paired with initial and annual follow-up school-based educational interventions tailored to middle adolescents between 15 to 17 years of age, covering HPV-related cancers and targeting both genders. This has been, carried out the study by Floyd T. Wilson et al. And found out that this helped in the uptake of HPV vaccination. Measures to reduce the burden of cervical cancer in Nigeria. Training and education can play a major role in reducing the burden of cancer. We have mentioned all of them: training of healthcare professionals, primary healthcare reorientation, where some of these things should actually be done, tailored evidence-based interventions, scaling up educational interventions, effective communication strategy, and of course, promoting screening and prevention altogether. What is the good news? The good news is that Nigeria, to vaccinate 7.7 million girls against the leading cause of cervical cancer. This was in 24th of October 2023. We should clap for ourselves now. We're heading somewhere. Let's clap for ourselves. So the drivers expected to improve vaccination in Nigeria. Several factors are expected to improve the vaccination coverage in Nigeria. Well, we'll talk about the single dose schedule updates, because people are talking about 0 to 6 months. The Vaccine Alliance, a global public-private partnership in order to make sure that these vaccines are available all over the country. National Strategic Plan on Prevention and Control of Cervical Cancer in Nigeria. It's currently is being driven by the Cancer Institute in Abuja and other people. Of course, funding and technical support by the Vaccine Alliance. All these will be expected to improve vaccination, HPV vaccination in Nigeria. So let us look at the Australian case study and see whether we can learn anything from it. HPV vaccination in Australia. They had an early introduction and education resulted in successes. The implementation in Australia in their HPV vaccination program, the schedule is 3 doses with the quadrivalent vaccine. But the basic thing is that the success component was that vaccination was introduced early, schools and communities were actively engaged, alluding to what MRH just told us, and of course, vaccination schedules were diligently met. I think we can learn from the Australian experience as we roll out our program in Nigeria. Components that ensured success was availability of care, education, and social media campaign. As Dr. Morin said, we have the tools now. Our phones, our social media handles can be source of disseminating this information. And you will see that the success drivers will be: number 1, cost benefits of early dictation; number 2, availability of universal health care; number 3, well-attended schools; and of course, social marketing campaign. Factors preventing success: number 1, the need for parental consent to vaccinate, because if someone between 9 to 13, you must get the consent of the parent to vaccinate. And of course, lack of prior knowledge of HPV vaccination. There was a considerable reduction in incidence and mortality. There was a 75% reduction in incidence and about 45% reduction in mortality. These are all experiences that we can learn in rolling out our program and escalating our program. So in conclusion, education and community involvement can help to overcome these barriers and achieve success for our HPV vaccination program. HPV is a major cause of reproductive organ-related cancer, especially cervical cancer. Screening and vaccination are effective to reduce the incidence and mortality of HPV-related cancers. And of course, finally, there are several barriers to improve in screening and vaccination in Nigeria, which we shall overcome. Thank you for listening. So, there will be 7 more series of these lectures, and all the other 7 will be virtual. Like I said, the next one is on December 7th, and the links will be sent across. Thank you.
Please, let's put our hands together for our Secretary General. When I was introducing him, I know what he can do, and he did marvelously well to this presentation. Please, let's put our hands again together for him. And the time is very far spent, but just as the summary, he told us a lot about HPV infection, the latency period, the different strains, the different things it can cause, both cervical cancer and other cancers. It's not only cervical cancer, even the benign lesions it can cause. He elaborated so much on our HPV vaccination. The current state in Nigeria, we were told they vaccinated 7.7 million girls. They also issue of vaccine hesitancy, and he went further to elaborate on measures we can take to increase our vaccine uptake. So it was very marvelous. And also he went into a case study, the Australian study. We can also follow such for us to increase our own vaccine update. And with that, we'll be able to reduce the morbidity and mortality associated with cervical cancer in Nigeria. Please, let's really put our hands together again for him. And just to round up, maybe we take 1 or 2 questions. I know you've... No question? Okay. We're so sorry. maybe we also discuss outside. And as he mentioned, remember we still have 7 different series still coming up. Please do endeavor to join us. Let's work together and eliminate cervical cancer completely out of Nigeria. Thank you and have a good night.